This is Dr. Ryan Gianatasio. He's recently joined our group in the neurovascular team with Dr. Kim. He's been recently coming from South Carolina. He originally had spent a lot of time around Dallas-Fort Worth area. He completed fellowships in vascular neurology as well as interventional neurology and is a neurologist. And I've met him professionally a few times already and happy to have him here.
Thank you.
Thank you.
Thank you, guys. Can you hear me okay back there? Good. I know it's been a long day. My goal with this topic is not to get too deep into the weeds, but kind of give you guys sort of an overview, not of stroke, because that's very immense, but just sort of focus on the acute intervention beyond TPA, TNK, and what we can do as far as clot busters, and just kind of hone in on the new procedure that we can do for acute stroke. I'll mention some kind of trials and things in there, but the goal is just to kind of give you a kind of broad spectrum view at it, maybe demystify it a little bit if you've heard some things about it, but let's get started. So as we kind of just heard a little bit about me, me and my family moved here in June from South Carolina most recently. We got drawn to the Black Hills and are settling in quite nicely. I think I'm getting indoctrinated pretty well. Got hail damage on the truck already. Got that, piles of grasshoppers and stuff everywhere. One of my dogs got bit by a rattlesnake, so I got the bill for all that anti-venom that she got. She's fine, but I'm getting used to it. Haven't quite hit her first winter yet, so we'll see how it goes. I'll stay. I'm from New York. My wife's from Texas. That much, she might be running away. But anyway, so a little history about the procedure, kind of where we're at now and how we pick patients, and then sort of the future, or where I think it might be going, is probably more of an opinion-based sort of a couple of slides that I'll share with you guys. Objectives, obviously, as I mentioned before, mostly surrounding sort of how we pick patients coming in to the ED for this procedure. I'll start off with a case report quickly. So this was a 67-year-old woman who I think she was eating at Applebee's. I may have the restaurant wrong, but Applebee's with her daughter and niece, kind of slumped over, garbled speech. At the time, they weren't really worried about her right-sided weakness. I think she even got the Heimlich maneuver because they thought she might be choking. Presented to the hospital because it was witnessed, presented to the hospital pretty quickly. Did get IV TPA. What this is showing, I'll try to work my way at both sides here for everyone. But I put an arrow in there, so it's pretty obvious. What you don't see, it's an indirect view of the thrombus. So basically, you just see as far as the dye can go, and then you kind of see it sort of cut off there. Not so easy to see sort of on that axial view, but there you go. So she definitely had a large vessel occlusion, left middle cerebral artery. This is kind of one of our go-to tools to make that patient selection. You might have heard of it. It's called Rapid AI, or Viz AI is the other company that does it. Essentially, it's using the same CT perfusion imaging software that we've had, but instead of relying on manual manipulation of all the data, which was time-consuming because I remember doing it as a fellow, it kind of inputs it into this AI algorithm, and you get spit out this kind of pretty-looking map. And what it was kind of showing here is on the right side of the screen is what we would consider penumbra in the green. So that would be a increased Tmax time or transition time through that tissue. And if you kind of split this map in half, where this is really the same slice as this, just kind of laid out like on a big table instead of as we were able to kind of scroll through it. So This slice kind of matches up with this one and so forth going up the line. What we're looking for on this side is showing penumbra in green or maybe salvageable tissue. And then on that left side, it would show pink for what we think is infarcted tissue. So in this case, the patient's got a lot of penumbra. No infarct is per this scan, and this would be a favorable candidate to take to the angio suite for intervention. We don't wait. In the past, we had waited to see if the TPA worked. You basically just stand there at bedside and see if the patient got better while the TPA is infusing. Now the recommendation for years has been you don't even wait for that. You just kind of take them to the lab and proceed. Sometimes, surprisingly, that vessels open when you get them to do your first injection, but oftentimes it's still occluded even after the TPA, T&K. So there's that. This is that AP angiogram, first run. I don't know if I'm doing that. Is that me? No. Okay, that'll work. All right. How come it's so little? There you go. I don't know why it's overlaying like that, but okay. So it's hard to see here, but the first catheter, that first ring around there is the aspiration catheter or the suction catheter. And then beyond that is the stent retriever, which is a stent that remains on the wire. It's not meant to be deployed or released. It's really just meant to capture and kind of drag out. You can use either technique. I tend to use both. I think it's more effective. And trying to pull the clot just from the end, you kind of support it with the stent retriever, but you can kind of see what that looks like angiographically. Okay, post results, because obviously I'm going to show you a good picture. I'm not going to show you the one that didn't work. There's basically that vessels we were missing prior to in this case. And this is kind of a post picture. The left is the follow-up MRI, which I'd like to get around the 24-hour mark. I think it's letting a little time go by is helpful. And then just next to it, compared to that previous penumbra from before, you see that the patient still ended up with some strokes on the periphery. You know, are there little fragments that break off that we can't really see? Or does that occur with the thrombectomy part of it? Possible, but I think you can appreciate how much tissue we kind of salvage there in the middle. Afterwards, this patient did regain speech. I think she still needed some therapy for some weakness, but this is a patient that could return to a normal life that wouldn't have if that penumbra had remained that big, because that's kind of where all our language kind of lives. So very good case for her and for our team at that time. So just to kind of give you some background to all this, it was kind of a little bit the Wild West when I started in 2012. This is hard to see in this kind of layout, but essentially, I'll just switch sides over here. It's basically the beginning of time until now. And we really didn't have anything to intervene with stroke. In the 50s, we had this carotid endarterectomies were developed. Aspirin, I think it was 76. Can't even read this, but was identified as a potential preventative medication for stroke. The 90s, we got the NINS trial with TPA. So really, from the beginning of time until 1995, really didn't have anything to change the outcomes of people having strokes. They just happened to people. And so early 2000s was sort of the birth of potential interventions for occlusions of large vessels in the brain. I think a lot of what my field has learned has come out of the cardiology, because they were doing it before us, and a lot of things were adapted from that field. Some things work, some things don't work. So they've kind of made a divergent path sort of since, but I think, you know, in the early stages we borrowed a lot from cardiology. The The early devices were the Mercy device, which is up here, kind of corkscrew-looking device. I think you'd put it past the clot and pull things out. And then the second device, I was never allowed to use by my attendings as a fellow, because it was the early suction catheters. And then this thing was basically a spear that you'd poke the clot in the brain, and then somehow that was supposed to be good. So as you can imagine, no attending was letting me as a fellow use the spear. It kind of fell out of favor for obvious reasons. We had a lot of perforations and caused a lot of bleeding, theoretically to try to break the clot up and suck it up. But that kind of since has fallen out of favor. But this is sort of, I think there's a lot of big learning curves with some of this stuff. Early trials, patient selection, or patient trials that were done early on. The big one was kind of an amalgam of a bunch of trials going on called IMS3 in 2013, showed that there was no benefit of intervention over medical treatment, including IV TPA. This was followed by a few other trials that supported that. And this was right, I think I was just starting second year of my fellowship. I remember my brother, who's an attorney, texting me. He said something like, "Bro, I heard that thing you went to Texas for doesn't work. What are you doing now?" I think he probably just saw a headline or something, But he had to go, like brothers do, they bust your chops, So I'm like, oh, thanks a lot. So what came out of this was essentially, it was the Wild West, as I said, sort of patient selection. It was up to the institutions and the physicians just to decide who they either cherry-picked or whoever they did these interventions on. Did it work? Did it not work? Time frame was all over the place. They can kind of take anybody they wanted, just give it a shot. I think prior to my fellowship, when I was at my residency institution, one of the directors kind of didn't really even believe in it, so he'd have sort of his fellows try it. And so I think it was all of those kind of cases that kind of led up into it not being show benefit at that point in time. But why do we still want to do it? Well, obviously, I would place the bet when moving to Texas that it would work. But here's probably the main reason, is that if you leave, despite it showing no benefit, if you leave these clots, the chances of severe disability and death in 90 days is upwards of this. Some other trials suggest a little bit less, but it's like 80%, which is horrible. So we still have to figure out how to do this, show benefit, and show that it could be safe to replicate around the country and help patients out. Okay, so this is going to be very hard to read, and I'm not going to get into the weeds, but after that, I think that was at the International Stroke Conference in Hawaii in 2013 that showed no benefit. It was like this cascade of insurance companies not paying for this treatments. C-suites around the country were kind of not interested in having interventional stroke programs. And so it kind of started to spiral a little bit. A lot of people around the country quickly got things into place to start a number of trials, and this was kind of like the top 5 labeled up top that quickly by 2015 had enrolled enough patients that started to show benefit. In fact, one trial after the next stopped enrolling in the medical arm because it was kind of unethical at that point. They had enough data to support that we can't ethically put a patient and not treat them to have a control. So a lot of these trials stopped early because of the immense benefit. And you can kind of, well, you can't if I do that. But down below, you can kind of see that the benefit of the thrombectomy versus the medical management, which could include TPA or not, but the addition, this would be the thrombectomy piece of the puzzle. This slide, what I wanted to kind of show here is that it doesn't make everything back to normal with these interventions. The trials did show that we pull a lot of the patients that would have normally have been dead or severely disabled. We kind of pull them out of those categories and then up into the moderate disability or even back to normal, or modified Rankin of 0, which is sort of a scale we commonly use in the stroke world, which is labeled kind of down over there, where 2 or better, you might have something that's not back to normal, but you're probably home, back to the activities that you enjoyed before. So it doesn't, removing a clot in every circumstance doesn't make everything A-okay, but as you can kind of see from this transition up here, that we're pulling patients that would otherwise be bedridden, feeding tubes, dead, and then potentially up into higher categories. And so that's what kind of those trials did show. Another thing that it showed is that the number needed to treat for this procedure is very powerful, that you don't need to perform this procedure a lot to show benefit. It's sort of up there with some of the interventional cardiology procedures that you don't have to do hundreds of these to see benefit. I think it's 2 or 3 or something like that. So a very powerful procedure in the results. So where are we at now with all this? I'll kind of give you this is sort of current patient selection and how we're doing things around the country today. This is what my kids think when I say present day. They hear presents and then kids come out of the woodwork. You say toy or something like that. Anyway, so patient selection. So in the past, they just put anybody on the table who might have a stroke. Now we want to identify a large vessel occlusion. We want to know that there's something blocked that we can intervene on. So everybody who comes into an emergency room, whether it be a primary stroke center or kind of a spoke and hub kind of thing, should get, if they're having acute stroke symptoms, get a CT head. We want to rule out hemorrhage first, because that would be a contraindication for thrombectomy. Another thing we want to see if we can identify an occluded vessel, so we always recommend CT angiogram. Another thing that's kind of gray, depending on the situation, is this modified Rankin of 3. We don't feel there's great benefit that if a patient is, bedridden with a trach and a peg, that maybe undergoing a thrombectomy is the best thing ethically for them. Or a patient on hospice, which I've done and kind of found out afterwards. So that's important to kind of know whether what's their current situation. Notice I'm not really mentioning age, because I think that's highly variable as a patient's kind of functional status. So I'd much rather go off of that rather than age. I think the oldest thrombectomy I've done is certainly over 100, maybe 101. Current standing is that symptoms should have started within the last 24 hours. The sooner the better with these thrombectomies, but at least that 24 hours can encompass the wake-up strokes, patients who went to bed normal and then woke up or fell out of bed in the morning. We don't know exactly when that stroke happened, so we kind of call that a wake-up stroke, and we have to go with when they went to bed or when they were last normal the night before. So hopefully they haven't been sleeping for 24 hours. Or this potentially captures those patients that live on their own independently, and then the kids come by a couple times a day to kind of check on them. Hopefully that encompasses more of the patient population. In the past, what I didn't mention in the kind of the history of all of this is that window has been kind of growing. Initially it was 6 hours, then it went to 8 hours, 12 hours, and then we currently have shown benefit up to 24-hour mark. So that's kind of where we stand as far as our window of opportunity to help patients out. Another thing we do with the CAT scan is we don't want to see any large developed stroke on the CAT scan. The ideal CAT scan is one that essentially looks normal. I'll show you pictures of that here in a second. So here on the left, you'll see a patient that has some stroke there. The deeper structures are otherwise intact. A lot of the cortex is intact. So this is still potentially a good candidate, depending on what the perfusion shows. If somebody comes into the ER with a CAT scan on the right, you can see sort of that large right MCA stroke already developed. It takes a little while for the stroke to develop on a CAT scan. Some would say 4 to 6 hours. I think that's kind of hit or miss, but it didn't just happen outside the hospital. This is probably a person who went to bed, had the stroke, and kind of came to the hospital in the morning after the strokes had some time to develop. Here's another patient that's not a great candidate to go to the lab. Here's a focal hemorrhage in there, whether that's primary or it was a stroke that converted. Unclear, but this is not something you want to go in. Very high risk of making that much worse if there's an occlusion on that side. So sort of the ideal patient is what's here on the right, which is essentially a normal CAT scan, which a med student once asked me, she's like, why do we keep giving TPA to people with normal CAT scans? That's kind of what you want. They have clinical symptoms and they have a normal CAT scan, so you know hopefully you've caught that stroke in a decent amount of time, and so that's a good scan to intervene on. When I talk about the penumbra and the ischemic core, this is kind of what I'm talking about. I mean, it's kind of stylized. It's not always sort of centered like that, but you can think about a chicken egg or a fried egg, where there's some centered core that's probably irreversible damage, but there may be a zone around the stroke, what we call the penumbra, that's basically tissue that's not dead, but maybe starving for glucose and oxygen, that if we reestablish flow, that we might actually bring this tissue, prevent this tissue from going on to infarct. So that's what we call the penumbra there. Here's another couple pictures of that rapid AI. Right now, we only have this ability at Rapid City. So a lot of patients that might have an identified occlusion at Spearfish or Custer would still need to come into the Rapid City Hospital. And the first thing we really want to do is get that perfusion study done to see if they're a viable candidate for thrombectomy. Patient here on the left, we see, I don't have the numbers on this one, but obviously you can see there's a lot of penumbra, a very small core, a big difference between the two. The penumbra, the green, is actually going to incorporate both the pink and the green, so it's really the difference between these two is what we can salvage. So, across the room, everybody can see that there's a big difference, and there might be a lot of tissue to save. So that, am I done? Is that it? No cowbell or anything? Like, no? All right. So you can see the patient on the right where the penumbra, the green and the pink are sort of kind of matched up. There's really no big difference between that. As you know, the penumbra is incorporating the ischemic stroke. There could be a slight difference. There could be 1 or 2 mLs of difference, but that's not going to benefit the patient to go in and pull out that clot. It's probably not going to be clinically beneficial to them, and all you're going to do is put them at risk for having reperfusion bleeding. So if you happen to get a patient or you hear about it, well, we sent them to the ER, they got a perfusion, but they didn't take them to the lab, we don't know why. These are a lot of the things that go into picking the right patient to get this procedure done. And so it's not just an interventionalist like myself or Dr. Kim. It does take a team. Right now we're able to do 24/7 here at Rapid City. This is all done in a biplane suite, which the benefit of that is we can see both the frontal view and the side view at the same time. Just for you guys to know, for me, I think I drive or steer the catheters through the AP view, like to get up to the middle cerebral artery. But the lateral view is what I use to kind of know, are we getting filling of those MCA branches. If you look at them sort of straight on as that previous case study, they're all kind of lined up and they're really just laying on top of each other. And it's really helpful to get that sort of side view to know, hey, are we getting somewhere with the procedure? I'll skip the animation. It's really just driving a catheter up somebody's head. But I'll just kind of point out that the two big devices that we have currently for removing clot are the aspiration catheter. This is one kind of here. They're built in a way with some radial force so that when they attach to a clot, that they don't sort of collapse under suction, that they hold their walls open and still can aspirate at the tip, which is a challenge when you have a catheter going from somebody's groin all the way up into their middle cerebral artery. So that's still a major way of doing it. The catheters have improved over time. And then here's the other technique, which is called a stent retriever or stent retriever. The goal of this, once again, is not to deploy a stent to open up the blood vessel, but the stents are actually put past the clot, and then the microcatheter is withdrawn, so the stent actually opens up within the clot. So the goal of that is that it's sticky. This is sort of a metal mesh that it'll kind of stick to it, and you can kind of pull it out with that clot on the end of it. Some people use one or the other. Some operators use both, which is what I do. I think it's just what you're used to and what you feel comfortable with. Come on. All right. So this is a real-world picture of a stent retriever and the clot sitting on it. When we see these pictures kind of blown up, just remember these vessels are kind of small, 3, 4, as high as 6 millimeters. It's still kind of small, but it doesn't take a lot to clog them up. So, sometimes people are like looking down at the clot and they're like, that's it? I'm like, well, that's all it takes to block up a 2 millimeter vessel. So what you might see in sort of the notes, or if you read any of the op reports, if you get these patients on the floor or in the community, we put a TICI score, which we kind of stole from cardiology. It basically kind of is a nomenclature at how successful that thrombectomy was. Sometimes you make multiple passes at a clot and it does not want to come out. And then you would write TICI 0, like it's unsuccessful essentially. And sometimes that might kind of help you kind of understand, well, they got the thrombectomy, but TICI 0, well, it wasn't successful. But you'll see that in kind of our notes and our op notes. Post-procedure care is essentially the same as our TPA patients, TNK patients. We like them to go to the ICU for a good blood pressure control. The only difference, I would say, is that if there is successful reperfusion, I do like to drop the blood pressure down to less than 140 with either cleverprex or cardine. Something with an IV drip. I don't really like IV pushes because I think you can kind of mistreat or undertreat at times. So really having that drip and dialing it in overnight in the ICU. Good nursing eyeballs on these patients. So I think the blood pressure is sort of the biggest, most important thing post-thrombectomy in these patients. I will give aspirin. I don't like to kind of load them with Plavix and all sorts of things because there's still a risk of reperfusion bleeding. Basically we opened up the floodgates. We can't tell the blood to go to the good tissue and not the bad tissue. It kind of goes everywhere. So these patients are at risk for reperfusion bleeding overnight. So I kind of like to leave things, and if they got TPA or TNK, that's fine. But I usually don't want to load them with aspirin and Plavix and other things quite yet until we get some follow-up scans in the morning, essentially. So what does the future hold for stroke and intervention? Like I said, a lot of this is sort of my opinion, but it's sort of out there and a common opinion, but opinion nonetheless. So I think there's 4 major areas that still need work. Since those trials in 2015 showed benefit, there's been sort of an explosion of thrombectomy capable and comprehensive stroke centers growing around the country. I think that's because we still can't overcome geography. This transporting patients 6 hours is really not helpful. So having multiple centers sort of everywhere is of the benefit of patients. There's still obviously can't be interventionalists in every single hospital, so there's still a lot of work being done on improving transfer times, because even if you have, you've all probably have seen it, where there's patients nearby, but it can potentially take hours to get that patient to another facility. So trying to find ways to decrease that door 1 to D1 to D2 time is still an option. There's talk about skipping TNK and thrombolytics. I think that's less of an issue now that the country has gone more towards TNK treatments, which are much quicker than TPA used to be with the 30-minute infusions and all that sort of stuff. But that's always been a discussion. And then, the other segment is this improvement of catheters and devices used to get these clots out. We still basically have that stent retriever aspiration kind of system. There's still companies working on making that better, faster, safer, less chance of perforating vessels, easier to prep on the back table, basically cutting down that time from when that patient rolls into the room to getting that vessel open, which is the most important part of the procedure. Last 2, which is kind of the holy grail of stroke medicine, is this neuroprotection. Is there something that we can give easily in the field, potentially, even by like EMS, that can buy that patient more time? There's a lot of trials in the past with magnesium and other novel infusions that I'm going to shut down again. This is a current trial giving an immune modulator, which kind of kicked off in April, to see if that has any benefit on keeping that penumbra alive a little longer for those patients who may be kind of a little bit further out from a thrombectomy center. And then lastly, which is sort of kind of an ongoing topic of debate, is there really even a time window for this? Or should we be more relying on patients, do they have collateral flow through an ACOM or a PCOM? What does the perfusion show? Some people will say, I don't care if it's 28 hours, but if the perfusion's good on that CT perfusion scan, I'd still consider taking that patient. Right now, that's sort of still up in the air, and maybe we go that direction to kind of maybe capture some more patients on that cusp of that 24-hour mark, but nothing is set in stone. So currently, we're still looking at patients in that 24-hour mark for intervention. Thank you.
Okay, do we have questions? Anybody with questions?